what I'm going to do today is do a presentation on the use of virtual reality for exposure therapy, for PTSD. Virtual reality goes to war, and talk a little bit about how that work's evolved, the theoretical basis for it, the research, talk about the extension to sexual trauma and work in Ukraine, and then talk about a new project that we have going that my colleague is demoing here called Battle Buddy, Sharon Mosguy. She'll be on the next panel, the Mission Daybreak panel, and you'll hear a lot more about that, but I'll try to hand it off to her at the end of this talk. So just to get some of these perfunctory slides out of the way, some of you have seen me speak before, have seen these a couple of times. I'm at the USC Institute for Creative Technologies. Over the years, the MedVR lab has evolved in 4 areas: psych, cognitive, motor, and virtual humans. Since the early days, that's the first BraveMind application from 2004, virtual classroom for testing kids with ADHD, a project that funneled around game-based physical therapy, and our first virtual human project, which was a virtual patient for clinical training. And fortunately, the work's evolved. So this is what all these projects look like now, and a number of them are moving towards productization. And that's become a little bit more of my focus. I've cut down a little bit of time in the lab and spending more time in private industry to try to get this stuff out the door, escape the lab. With that, another old favorite slide. When I look at VR, clinical VR, I look at aviation simulation. So, best metaphor is just like an aircraft simulator serves to test and train piloting ability under a range of systematically controllable conditions. We can test, train, teach, and treat human functioning using simulation technology. And in some sense, it's the ultimate Skinner box. A controlled stimulus environment that allows us to systematically manipulate stimuli in a way that can help people overcome fear, address trauma, deal with pain, learn how to regain function, learn ways to interact with people, with virtual humans, and on and on and on. And by the way, that's a ChatGPT image, and you can tell it's got its classic hallucination, the tail coming out of the chair. I don't know if you notice that. But anyway, so since 1994, when the field first got its traction, primarily with exposure therapy for phobias, we've seen a wide range of areas evolve. And not only has the technology caught up with the vision, but the science has come along as well. We have probably the largest and most systematic scientific literature of any VR use case in the field. And one of the early things that was learned in 1994 was that it didn't have to be an exact replica of reality to have a clinical effect. So that was a fear of heights scenario from Barbara Rothbaum's work, very cartoonish. And we learned that we could fool the brain, that in spite of the impoverished nature of the graphics, people still emotionally engaged with it, particularly people with phobias. They're especially primed for this stuff. The good news is, the technology, the software, everything about the field has evolved dramatically. And I always like showing this one because I'm a cat lover. You have to go out and rescue that little kitty cat off the plank. But anyway, the field has evolved quite a bit. And I'm very happy that we have an event like this where, probably the largest healthcare network in the world is embracing this and getting it and doing the hard work. And a lot of it unpaid work. A lot of it is just passion people have for veterans. And I think that's an important thing. Anyway, going back to phobia stuff a little bit, in the beginning, there was exposure therapy. And this was one of the first areas, along with some cognitive assessment and training work in the mid-90s. And, you know, the reason it got its traction was because it made sense. It was theoretically informed. It was an evidence-based approach, a behavioral approach for treating people with anxiety disorders. And so it was a small step to implement VR, and it made a lot of sense. You know, a variety of applications, as you see here, you know, have emerged over the years, a ton of science, a ton of studies. And even with populations that previously would have been thought to be kind of hands-off for VR, people with impaired reality testing, you know, now being found that we can help folks with clinical conditions that are quite severe, and we can do it in ways that might help them by having them participate more on their own independently. So this work with the Game Change application, I think, is a good illustration. But it also illustrates the trans-diagnostic approach here, because it's not just schizophrenics with agoraphobia. There's plenty of veterans that have a hard time leaving their house. So these tools, you know, can be applied for different populations, different clinical conditions. And I think it really shows the power of VR, even if in the scientific community there are you know, little turf battles about what's the best approach, what's the best treatment. VR is agnostic, you know, as we'll see in a minute. Anyway, a paper that was published on this work. Let me move forward. So let's talk a little bit about PTSD now. It follows the same process, same strategy as working with folks with phobias, help people to confront and reprocess difficult emotional memories in a safe place under the guidance of a clinician. Now, the clinical guidelines for the VA came out last year, Paula Schnurr's group, and they recommended 3 trauma-focused therapies: prolonged exposure, CPT, cognitive processing therapy, and EMDR. And from that, there was a little bit of a food fight. You know, some folks say, oh, well, you know, we got to get away from trauma-focused therapy. Even though there's a ton of research documenting it, it's not perfect. People drop out, people freak out maybe, but, you know, it's an evidence-based approach. And we have to look at the evidence, but we also have to realize that PTSD is a complex condition, and there's no one-size-fits-all magic bullet. And VR can be used to deliver a lot of things that support people that are going through various levels of PTSD treatment, whether it's teaching them how to relax or be mindful, or you're doing the hardcore direct exposure work. And the same kind of turf struggles going on over on American Psychologist. That's from this month as well. So a lot of turbulence in the field, but that's okay, because VR can be used to deliver EMDR. It can be delivered to teach mindfulness. It can be delivered to help people overcome their social interaction or their fear of being in public places. So for us, though, the exposure model has served us well. And our group and another group in 2008 did a meta-analysis documenting the value of VR for these purposes. In 2015, a larger meta-analysis, more literature came through, same positive findings. 2019, Journal of Anxiety Disorders had a special issue on VR, and in this meta-analysis, they made a pretty bold claim. And more recently, and I highly recommend, this one fell under the radar for me. I just found this about a month ago. This is a great systematic review. They detail a ton of studies across a range of clinical conditions. So I highly recommend this. But one of their findings, of course, was that of all the areas, anxiety disorders and PTSD have pretty solid scientific literature in support of its use. I mean, still, science never sleeps. We got to continue. We got to understand who we can predict may benefit from VR as opposed to other methods. And so the rationale is, I think Joanne DeFede said it properly here. We're using VR to help people to engage. We have an emotionally evocative technology here. We want to help people engage in a safe way with their trauma memories. And that's the basis for exposure and trauma-focused therapies, because a lot of patients have a really difficult time. You're asking someone to imagine and talk about the thing that they've been avoiding addressing or confronting or talking about for months, years, decades. And so VR is a way to do that. We have some science to document that. So we got involved in the field in 2004. We built a prototype which looked like this. It was built off of a game. We didn't have any funding. And it was a very basic thing. We took a street out of this game, added some buttons where you could make ambient sounds, hit another button on the computer, maybe gunfire. So we could systematically add in stimuli at a pace that the patient could handle. Bring in a helicopter. And we shopped it around, but we couldn't get anybody to fund it until the Hoag article came out in July 1 in New England Journal of Medicine saying we have a real problem with PTSD and we need to attend to it. At that time, Russ Schilling, who's sitting here, was with ONR. He saw the work and funded it. And one of the cool things was when we had built this, we actually sent a version to Iraq with Greg Rieger, who's a VA psychologist at Puget Sound, and he actually got user-centered feedback, vet-centered feedback about what we got right, what sucked about our application, what would be better, what would serve the needs population better. And that aided us dramatically when Russ came, our knight in shining armor from ONR, and got us funding, and we built a 4-scenario world that looked a little bit like this: driving worlds, foot patrol, and so on. And it was informed by that user-centered design, but it was also informed by a non-veteran who was in a war zone, as you'll see here.
I have to tell you, I was stunned by my reaction. I mean, I know it's only a simulation, but my reaction was so powerful. What I didn't show you was that I went through that simulation 2 more times. And I can't say that it ever really got any easier, but I did feel more in control. And from what the psychologists tell me, that's the goal. Face your fears until you can control them, maybe even defeat them.
So if you want to see the whole thing, it's like 5 minutes before, he had a visceral reaction when he was going through it. He thought it was just going to be a video game. And so anyway, it's on my YouTube channel. If you just punch in my name on YouTube, you'll get to it. Okay, next, this is in 2011 or 12, we got funded to rebuild everything on Unity. We went from 4 worlds to 14 worlds. Our mantra was diversity over detail. A lot of diverse types of content were needed to address a wide range of needs. And
by going through it there, it's not going through my head at night when I'm trying to sleep or when I'm with my wife, when times when I don't want it to come up and me start thinking about it. Traumatic things are not normal. You cannot handle the things that you've seen and done. And this is a tool that has helped me out tremendously.
Reliving the worst moments of his life has helped him to move on with his life.
I'm probably about 80% of who I was before I left, but I think that's pretty good after seeing and doing the things that we've done.
For Nightline, this is Dan Harris in Atlanta.
Okay, so one thing to keep in mind, as cool as all this is, it's not a replacement for a clinician. It's simply a tool to advance the skill of a well-trained clinician. And this is one area where, you can talk about, pushing a little bit more therapy back into the home, and that might be useful, but it's got to be under a clinician's guidance when it comes to trauma. You really need to have that kind of tight supervision. So I don't think AI will be replacing us in the field of trauma therapy too soon, although I could be quite wrong about that. But the way we do that, a clinician has a control panel. So in real time, they are controlling everything that goes on in the virtual world, the time of day, the lighting, the sound effects, explosions, planes flying over. And so it's a very clinician-involved application. With the clinicians essentially a Wizard of Oz. Let me just walk through some of the research. The first open clinical trial, first 20 treatment completers, the study that was funded by Office of Naval Research, Russ's group, and we got lucky. We got some pretty good results. These are the individual data points. 16 no longer met PTSD criteria at the end of treatment. 4 did not benefit. Those are pretty strong results. We just got pretty lucky on that because the results that followed were a little bit more moderated, but they continued with various researchers around the country doing studies with this. And this is one that followed people up to a year, Barbara Rothbaum's group. Another study and also along with that, they also used startle response, physiological measures, and cortisol reactivity, and showed that there was a correlation between those measures over time with clinical outcomes. This is one I love to talk about, Deborah Beidel's work, University of Central Florida, because it really underscores the combination approach that what she does is 3 weeks intensive therapy, fly into Orlando, get a hotel room. Each morning you do VR exposure, and then in the afternoon you do a combination, what they call trauma management therapy, which is a combination of traditional therapies that are customized to the needs of the specific user or patient. And I think it shows that it's a complex disorder. It works better, obviously, when you address a lot of these things when it's feasible. But I do think that the trauma-focused approach is kind of needed. Maybe you do something else to get them warmed up, but you gotta address the trauma. I don't think just any of these other therapies alone are going to give you the same level of effectiveness. Greg Rieger did the first RCT with the 4-scenario version, so it was a little bit limited, but got equivalent outcomes to prolonged exposure. Our latest randomized controlled trial with Joanne DeFede, Barbara Rothbaum, Chris Rice, or CAST, Mike Roy, showed that across comparisons with prolonged exposure and VR equivalents, everybody did quite well in this study. But in our pre-planned predictions, we predicted that people with comorbid depression, people that are hard to engage in traditional therapy, we predicted they would do better in VR. And in fact, that's what we found, so pre-planned prediction. And as well, when people were asked at the beginning of the study, what would they prefer if they weren't going to be randomized, what would they prefer to participate in? And 76% would have picked VR. So we've got some evidence for a preference or an interest in seeking treatment in this form for some folks that might not seek therapy in the traditional format. This was a study that just came out end of last year, just taking our US version and just applying it in Denmark, getting good clinical outcomes in an open clinical trial. And then another independent trial with transcranial direct current stimulation added to the VR exposure, showed some positive outcomes as well in terms of improving the success of people that got the TDCS or whatever it's called, but independent trial. We moved on to sexual trauma. We thought we'd have an easy go of it, simply modifying some of our combat worlds, but then as we started interviewing people, again, user-centered design, most sexual trauma was not in the military, wasn't happening in the trenches of Afghanistan, it was happening stateside. So we had to build out at the last 3 months, a bunch of civilian content to get ready for a safety and feasibility trial. And the findings from that, small study, 11 treatment completers, no critical incidents. That was the big reason to run it, to make sure we weren't going to, make things worse for folks. But even with a small sample, we got good clinical outcomes that were clinically meaningful and statistically significant across a couple of measures of PTS and also depression. So this work now is expanded with Penumbra's efforts to develop in vivo exposure of everyday environments using spherical video, doing this with the VA. Billy talked about this yesterday, Billy Rutherford, so I'm not going to spend much time, but you get the point. Everyday environments that you can help people to confront these types of experiences. I want to do a shout out as well to Soldier Strong, who serves to donate all the equipment and clinical training for the VA, for Brave Mind. It's been distributed across the VA, and as well, they also partnered with Penumbra to help get the first of the Penumbra Real systems out into the VA as well, and that's grown since that time. Okay, so now moving on to the translation of this work for other purposes. Virtual Ukraine, certainly, I think we can all agree it's pretty much a petri dish of trauma over there, the horrific things that are going on. And so we started, here, let me stop that for a second. We ended up partnering with a group in Kyiv, about 150 clinicians in a network, and found a developer that was willing to take our software. USC gave the actual source code to this developer, Svetlana, and I'm going to mess her last name up, Dragonovich, or anyway, she, her company, Very Real Health, part of Fountain Digital Labs, offered to start building this stuff. We've raised maybe about 10,000, certainly not enough to cover all the effort, but they were pretty cheap in Ukraine, actually, on software development. But here's what we have so far in this. We tackled a village, a burnt-out village first, where there's tanks, and it's sort of like the Anne Frank thing, where they're going to come and find us, kind of a thing. So we can systematically control all the stimuli, time of day, jets, drones, and so forth. And then a city complex with missiles and so forth. And you can actually go down and walk around on the streets for this one. And then the third world that's being created right now, I just have still images of it, is a combat scenario in a forest environment. This is just a little bit of what that looks like. Again, you can change, in this case, the time of the year, the weather, nighttime, night vision, stuff like that. All right, one other element of this project is, Virtual Ukraine project, is to build a metaverse world that refugees can gather in and get social support. And this is what that looks like. It was very, you know, it's sort of like Inner World, Noah's great work out there, where you can bring people together. And in this case, we just didn't have any money, so we took a spherical image of a popular square in Kyiv, and that's the world. And here's what the first pilot test, we're running an RCT right now, but this was what the first pilot test looked like.
Я приехала в Румынию со своими дочками, у меня 2 дочки. Столкнулась с проблемой языкового барьера, конечно. Первое время было тяжело.
So, you know, this is, it starts off by people talking about mundane, everyday adjustment issues. And then as they talk more, and there's a clinician involved in this, they start digging into some of the loss, the grief, and the hope for returning and so forth. So this is a project I'm pretty excited about, and it's being tested at the University of Bucharest right now. Working also with Jessica Stone to help get her virtual sand tray, a play therapy approach for helping children represent their trauma by creating a virtual world that they can create on an iPad, and then they can put on a headset and walk around in it and talk about their experience in a way that's not like direct exposure therapy, but it offers a window for these kids to be able to talk about the issues. And here's some examples. It doesn't have Ukraine-specific content. That's what we're trying to raise money for, is to build out some of that content, to make it more culturally relevant. But it's being used, and these are top-down views of examples of different worlds that kids have created where they get to talk about, the experiences that they've had. So that's ongoing as of now. And I think, as I mentioned, hope, some of these things are quite hopeful, the worlds that kids build. But I think this is as important as addressing challenges with warfighters and civilians exposed to combat. The idea that ACEs have a direct impact on later mental and physical health, and we need to address it. And there's research also showing that when people have physical assaults later in life, if they have a high number of these adverse childhood experiences, that they're more susceptible to develop PTSD. This study showed a high risk at 6 months. So anyway, and this is a really good article if you want to look into this area a little bit more. But, the incidence of abuse, neglect, dysfunctional household, violence, and so on, it has a real impact on people. There's no question about it. It's one of the strongest findings I think we're seeing in literature. We've got a couple new partners on the Virtual Ukraine project as well. I want to call out Shel Mann, who's currently healing from an injury, but he was all in on donating the sanctuary application for mindfulness, so that's going to be part of the general package, as well as Virtual Leap, who's donating their cognitive training and assessment applications. So trying to put together a comprehensive package of VR systems that all can run, in a similar space and clinic. Okay, and again, Soldier Strong heading up the charge and helping us raise money. If you go to their site, if you want to donate any money, feel free. Finally, I think I'm almost on time. I've got 15 minutes left. I wanted to do a little overview of Battle Buddy, which is, the traditional Battle Buddy is a real thing in the military where you kind of are assigned or you choose who's going to be your buddy that you kind of keep an extra eye out for, to watch out for. Well, we stole that name and created a virtual human mobile app that was funded by the VA through the Mission Daybreak program. I'm sorry, I should hold this closer. It funded through VA Mission Daybreak program. The panel is going to follow my talk where they're going to present and talk about the developments across the projects. But we proposed a virtual human mobile device with a character that you could bond with, like a battle buddy, that would be useful for health and wellness, but also would help you to create your safety plan, which you would always have in your pocket on your mobile phone. Safety plans are well intended. They're done at the VA routinely. And a lot of times you get a piece of paper. It's put this somewhere safe when you're in a state of emotional dysregulation. Pull it out and follow the steps, Well, having it in your pocket, on your device, and co-creating it with a virtual human is the vision for this. So I want to show some of the component parts. But first, here is the Secretary of the VA describing Battle Buddy, and then Battle Buddy is going to describe himself.
Veteran-centric innovation is what our Mission Daybreak grantees are after to help end veteran suicide. I just walked past one of the booths out front. I'm thinking about Battle Buddy innovators out at the University of Southern California Institute for Creative Technologies. They're working with Soldier Strong to see if interactive AI can help assess a vet's potential for suicidal ideation, prevent a suicidal crisis, and connect vets to mental health interventions they need in that moment.
Hello there, and welcome to Battle Buddy. My name is Kevin, and I'll be guiding you through our vision for suicide prevention and wellness. In addition to daily check-ins that focus on mental and physical well-being that can leverage data from a companion Apple Watch or Fitbit, I can make coping strategies easy to access, queuing up music, a book, or a route for a calming walk. We could also play a game of Wordle together. If there are friends or loved ones who can help, I'll have access to their contact info, and I can help the veteran make that call or send that text. And of course, if the veteran needs professional help, I can connect to emergency services.
So, okay, that's a quick intro. I want to just walk through some of the components. There's the safety plan, there's libraries of content, there's the daily check-in activities, wide variety of things that all are getting tied together. We have a lot of these component parts, and as I'll describe at the end, our aim was to partner with industry at the end to really productize it. There's only so far I think you can go in academic environments to build something that's really shovel-ready, and so we'll talk about that. But with the safety plan, there's ways to walk people through, provide options that they might not think about, engage with the character. But we also have elements where people can do some self-assessment. And what you'll see here is a model for an introduction, the administration of a self-assessment test, and then the immediate interpretation, all trying to do this in a calm, kind, non-stigmatizing way, because we do know that people do tend to let their guard down when they're interacting with virtual humans. They tend to feel safer. They self-disclose more personal information. So anyway, this is what this element looks like.
Some ancient Greek dudes said that knowing thyself is the beginning of wisdom. Oof, my back. I'm not the philosophical type, but I can tell you that doing an emotional inventory of yourself is one of the first steps in wellness. It's like an annual physical. Everyone should do it. This quiz can help you see where you are on the depression scale, and it only takes about 3 minutes. Just remember, the score you get isn't a diagnosis. It's simply one tool in your toolbox. Talk about the results with a health professional before making any big changes in your life. I'll give you some privacy to think about your answers, and I'll be back when you're done to help you understand the results. If any of those questions made you feel uncomfortable, I get it. That's totally normal when it comes to self-inventory. The most important thing is to be honest, so that me and anybody who's helping you can meet you where you're at. Let's take a look. This is a let's keep an eye on it score. It's normal to have days or weeks where you just feel off. Although symptoms at this level don't usually need clinical treatment, it's good to be proactive. Here are some options to help you optimize your well-being.
Okay, so that's one element of the process. Another element is giving actual tips and teaching tactics like tactical breathing.
Relaxation and breathing exercises are a game changer. These are simple actions that go a long way to reduce blood pressure and mental tension. One of the best is tactical breathing, a 4-count method of breathing that helps you relax and focus. First, I'll demonstrate this technique, and then I'll walk you through it slowly. After that, you can try to do tactical breathing. To do tactical breathing right, inhale through the nose for a slow count of 4.
So he'll demo this,
Hold for a count
he'll
of 4.
go through the breathing practice
Exhale
and so
for a
on.
count of 4.
Little
And
visualizations
finally,
will pop
hold
up.
for a count of 4. And then repeat. Let me show you what I mean.
So he demos it. I'm going to jump ahead here.
Breathe in.
Then,
Looks like you got it. Now you can try it on your own. Which environment do you find the most relaxing? Being surrounded by all of these trees is really peaceful. I love the sound of the ocean. I can stay and breathe with you, or I can give you some privacy. What do you prefer? Okay, feel free to do this exercise for as long as you want to. Just hit "I'm done" when you're ready to move on.
Okay, we show one more example of something I hope you'll like. This really was Sharon's vision.
Hi there, and welcome to Kevin's soothing, smooth sleep story space. When you have trouble falling asleep, I got your back. Today, I have something very special. The 1921 version of A Course of Pure Mathematics. Perfect bedtime material. So, settle in, relax your muscles, close your eyes, and take a deep breath. Let me take you on a pure mathematics journey. Chapter 1, Real Variables. 1. Rational numbers. A fraction r equals p over q, where p and q are positive.
All right, so you get the point there. And a little tip of the hat to Bob Ross. I don't know how many people are old enough to know this guy, the painter on public television, soothing voice, calming presence, died too young. Anyway, I think that was a little inspiration. But again, vet-centric feedback is essential. It's essential with any application development. You got to get feedback from your targeted user group if you're going to design anything of any real relevance for that group. So we've been doing that. We have actual veterans on the development team, and also have an internship program at a community college with veterans, a veterans program. So we've been trying to integrate that. We're moving forward with a larger scale, and we're looking for partners as well. But that'll come up in the panel following this. The other area, here's a quote. The other area that was part of our deliverable, if you will, was that at the end of our initial sprint development phase, we're going to look for partners to move forward in industry to be able to develop this and to develop the AI at a level where it would be more credible and more helpful and safe at the same time. And that's a big process. So, of course, Soldier Strong is involved in this, and also a new company, and I think this will be the first time this is going to be showed public, Sidekick Wellness, that has already built the intelligence infrastructure, and you'll see an example of a prototype now that I'm hoping will become embedded, kind of be the central nervous system in the future moving forward with Battle Buddy.
Now, can we take a look at my mental health benefits?
Definitely. You are eligible for mental health benefits through the VA Care Network. If you're in crisis, you can call the crisis line anytime. Otherwise, you can schedule an in-person meeting, have an online appointment with a counselor, talk with a care coordinator whenever you want, or do some whole health exercises like meditation. This short video gives a good overview of the VA's approach to mental wellness.
And one more.
Thing. I've heard the VA is using virtual reality to help with mental health. Any chance you can find some information about it?
Of course. Give me one moment to see what I can find.
No rush, thanks.
Here's a video about what the VA is doing with virtual reality.
VA wants to transform the way that we deliver care and the way that veterans experience care. One of the ways that we do that is through immersive technology like virtual reality and augmented reality. We know with these technologies, we're able to engage the whole patient, physical, mental, spiritual, and emotional.
So with that, I think you see where the direction of this is going, and the tremendous capacity that we have now with combinations of VR, virtual humans, AI, but we have to do it ethically and professionally, and it's going to take some time to get it all right. But we can't just turn our backs to the power of this, and I'm looking forward to I mean, what you saw there, that was a demo of the intellectual infrastructure of the Sidekick platform. That's there. Now we just got to refine it, apply it, put it all together, and of course test it with our targeted user groups. So,
no one should ever have to face their toughest moments alone. Everyone deserves a non-judgmental friend that is there when they need them the most. That's what I'm here for. I won't let our vets down. Together, we're stronger. I'm a friend, a partner, a buddy. I've got your 6. I am your battle buddy. Thank you for your time.
okay. So with that, I want to thank our partners, VA, Luminary Labs, Mission Daybreak, Soldier Strong, and you know, I think you'll probably get a deeper insight into this in the next panel, the Mission Daybreak panel. The PI for Battle Buddy will be on it, Sharon Mosguy. She's been demoing it out in the courtyard there. And so with that, I actually have a minute and a half left. I can't believe it. Wow. So thank you for your time.